Hello everyone, thank you for coming. My name's Shayla Jenkins. A little bit about me, I am from Kansas and I will be going back to Kansas for outpatient practice in Hayes. I will be staying one extra month because I had 2 children during my 3-year residency. My first child is 2 years old and my most recent child is 7 weeks old, so I apologize if I'm a little tired. I did write out my presentation because I thought my focus might be a little lacking given my 7-week-old was up hourly last night. Okay, so today I will be discussing the spectrum of disease called non-alcoholic fatty liver disease, or NAFLD. It's also recently been renamed metabolic associated fatty liver disease, or MAFLD, but I will just refer to it as NAFLD going forward. I'll briefly discuss our current understanding of the disease process, diagnostic criteria, risk factors for disease, and methods for screening. And by the end of today's discussion, my hope is you will become more familiar with this disease and how primary care providers can help screen at-risk populations and identify those patients requiring referral to specialists for further treatment. Okay, NAFLD, what is it? Well, it's a spectrum of liver injury that ranges from steatosis, or simple fatty deposits, to steatohepatitis, or fatty deposits with inflammation of the liver with or without fibrosis. The pathogenesis of the disease has not been fully elucidated, but the disease is generally thought to begin with insulin resistance that leads to steatosis, then a possible second hit of oxidative damage occurring, leading to inflammation. Hypothesized oxidative stressors include hepatic iron, leptin, antioxidant deficiencies, and intestinal bacteria. This inflammation within the liver is thought to lead to fibrosis, which can result in liver cirrhosis. So how is NAFLD diagnosed? Well, it requires the following. 1, demonstration of hepatic steatosis by imaging or biopsy. 2, exclusion of significant alcohol consumption. 3, exclusion of other causes of hepatic steatosis. 4, absence of coexisting chronic liver disease. However, I do believe that the last point of the absence of coexisting chronic liver disease could be argued against, as patients can have a combination of fatty liver disease due to insulin resistance with other forms of liver disease such as chronic hepatitis, and that these additive harmful effects these effects can be additive on the harm to the liver. So liver biopsy is the only method currently available to differentiate non-alcoholic fatty liver from non-alcoholic steatohepatitis and is considered the gold standard. NAFLD is diagnosed when greater than 5% of hepatocytes in a liver tissue section display steatosis with or without hepatic iron deposition. And then NASH is diagnosed in the presence of hepatic steatosis plus hepatocyte ballooning, degeneration, and hepatic lobular inflammation with or without fibrosis. So who is most at risk? Well, increased rates of NAFLD have been found in diabetics, obese persons, patients with metabolic syndrome, older adults, particular ethnic groups, those with certain genetic susceptibility, and those with a first-degree relative with the disorder. So NAFLD is found in 50 to 60% of type 2 diabetics and up to 45% of type 1 diabetics. Among patients with type 2 diabetes, NASH is a leading cause of end-stage liver disease and a risk factor for cardiovascular disease. Ethnic differences occur, and rates are highest in Hispanic Americans at 45% of patients with NAFLD being Hispanic, white Americans about 33%, and then black Americans have the lowest rate at 24%. Unfortunately, there is also a condition called lean NAFLD, in which patients have the disease with a BMI less than 25. This is actually less than 23 for Asian Americans or Asian people, due to dysfunctional adiposity with visceral fat accumulation. One retrospective study found that patients with lean NAFLD had higher 15-year cumulative all-cause mortality than obese NAFLD and non-NAFLD U.S. citizens. The lean NAFLD group is estimated to make up about 17.3% of all NAFLD cases in the United States. This emphasizes that BMI and obesity are not always reliable for identifying the right patients to screen. So why does this matter? If patients are not identified as having NAFLD, they may not receive appropriate management and progress to more severe stages of liver disease, including liver failure and hepatocellular carcinoma, and many of these patients are asymptomatic. It is estimated that NASH progresses to cirrhosis in up to 20% of patients and is now the leading cause of cryptogenic cirrhosis. Rates of NASH cirrhosis are only expected to increase with the worsening obesity epidemic. Additionally, patients with NAFLD have increased rates of cardiovascular diseases and malignancy and an overall increased rate of mortality compared to the general population. And with our aging population, this will only increase the healthcare burden to our already overburdened healthcare systems. One study demonstrated that screening for non-alcoholic fatty liver disease in type 2 diabetics in the United States is cost-effective. However, validated cost-utility studies on the effectiveness of screening for other high-risk conditions are lacking, and other studies have shown that general screening in the U.S. population is not cost-effective. So, guidelines among varying medical groups differ in regards to who to screen for NAFLD. This is also true between international organizations. So the American Association for the Study of Liver Diseases, or AASLD, does not advise routine screening for NAFLD in high-risk populations like obese individuals or type 2 diabetics due to uncertainties in diagnostic testing, long-term management, and cost-effectiveness, but endorses, quote, vigilance in patients with type 2 diabetes. They also do not currently recommend systematic screening of family members of patients with NAFLD. The American Diabetic Association, or Diabetes Association, recommends evaluating patients with type 2 diabetes or prediabetes and elevated ALT or fatty liver seen on ultrasound for NASH and fibrosis. The American Academy of Pediatrics recommends considering screening for NAFLD in obese youth with additional risk factors, such as central adiposity, insulin resistance, prediabetes or diabetes, dyslipidemia, sleep apnea, or family history of NAFLD or NASH. They report that the best screening test for NAFLD in children currently is ALT, and recommend follow-up screening for NAFLD by repeating ALT every 2 to 3 years in high-risk youth if initial testing is normal. Internationally, there seems to be more push for screening. The European Associations for the Study of Liver Disease, EASL, Diabetes, EASD, and Obesity, EASO, recommend screening for NAFLD in people with obesity, metabolic syndrome, and type 2 diabetes. The Asian Pacific Association for the Study of Liver, APASL, recommends screening in those with type 2 diabetes or metabolic syndrome, or those who are overweight or obese according to ethnic-specific cutoffs. So, NAFLD in the primary care setting. Primary care can and will play a significant role in identifying and treating patients with non-alcoholic fatty liver disease. I really liked this quote I came across on my review when reviewing the literature. Primary care takes up the bulk of identifying patients with diabetes, dyslipidemia, hypertension, and components of metabolic syndrome, and are the optimal providers to identify patients with NAFLD, make appropriate referrals to specialists, and arrange appropriate surveillance. Primary care will also be instrumental in treatment, as current evidence shows diet and exercise is immensely helpful in managing the condition and can even lead to a reversal of liver injury prior to irreversible levels of fibrosis. So let's say you have a high-risk patient and are concerned that they may have NAFLD. What is currently the best way to go about it? There are a number of serologic markers and imaging modalities that can be used as non-invasive ways to screen for and diagnose the condition, but the cost, availability, and accuracy vary. And in certain situations, there will still be a need for liver biopsy. So what are these methods? The current serologic methods for screening can be broken up between those that can give you evidence for steatosis versus those that have evidence for fibrosis. So the serologic methods to screen for liver steatosis include the fatty liver index, hepatic steatosis index, steatotest, and NAFLD liver fat score. For fibrosis, the serologic methods to screen include FIB4 index, NAFLD fibrosis score NFS, BARD score, and enhanced liver fibrosis test. I bolded FIB4 and NAFLD because they are the most useful in my going over the literature. The FIB-4 index is one of the best non-invasive tests for diagnosing advanced fibrosis and uses simple values like age, AST and ALT levels, and platelet count to estimate likelihood of fibrosis and need for liver biopsy. Accordingly, the NAFLD fibrosis score is another useful way to identify advanced fibrosis and takes into account BMI, albumin level, and the presence or absence of impaired fasting glucose or diabetes. But you must also adjust for BMI according to ethnic groups. Both the FIB-4 index and NAFLD fibrosis score are available on MDCalc. So current imaging modalities to assess for steatosis and fibrosis include the following. Conventional ultrasonography is a good predictive tool for steatosis, but does not provide information regarding fibrosis unless the patient is already cirrhotic. And conventional ultrasound has good sensitivity and specificity with an area under the receiver operating curve of 0.97 and is very readily available. Vibration-controlled transient elastography, or VCTE, also known as FibroScan, has better sensitivity and specificity with more severe stages of fibrosis. And the extra-large probe can be used in patients with elevated BMI that used to be more difficult to get more sensitive and specific measurements. It is not accurate in the settings of cholestasis, ascites, or congestive heart failure, however. There are other imaging modalities, including MRI, proton density fat fraction, spectroscopy, elastography, and shear wave elastography, but the availability and cost make MRI magnetic resonance less useful in a screening setting, and the shear wave elastography lacks well-established cutoff values and is only accurate if greater than 30% of hepatocytes are steatotic. So here is a proposed stepwise algorithm. Number one, you could start with an ultrasound to identify steatosis, given the good specificity and sensitivity and readily available presence of ultrasound. But if it's not readily available, you could use a serologic modality, such as a fatty liver index steatotest or NAFLD liver fat score to diagnose steatosis. So let's say they do come up positive for steatosis. Well, number two, the second step would be to assess for fibrosis using a non-invasive test with a single cutoff to exclude patients with a low risk of advanced fibrosis. So NFS, or the NAFLD fibrosis score, less than 1.455, or a FIB score of less than 1.3 for ages 65 or younger would give you this information, and then NFS of less than 0.12, or a FIB-4 less than 2 for ages 66 and older. So number three, the third step, if the patient does have higher intermediate results, you would then employ the FibroScan or VCTE to improve detection of advanced fibrosis in order to reduce the need for liver biopsy. But then in those patients where they have an extremely high risk or still have elevated risk factors, you could do the liver biopsy as appropriate. So as you can see, there's a long way to go regarding our understanding and treatment for NAFLD, as well as screening and who to screen, and if it is even cost effective. So where do we go from here? Well, I do think we need more studies to evaluate which patients should be screened and evaluating the cost benefit for that. And we could benefit from more pharmaceutical methods for treating the disease. But as a primary care doctor, I believe that an ounce of prevention is worth more than a pound of cure. And then I hope all of you have been inspired by this conference to live out the principles of lifestyle medicine so that you can model healthy behaviors for your patients. As we know, diet and exercise is still number one, and evidence in the literature already shows that good diet and exercise can not only prevent further worsening of NAFLD, but can actually reverse NAFLD. I do think primary care providers should continue to employ motivational interviewing and recommend these healthy eating and physical activity patterns to their patients, as well as live them out. NAFLD and the obesity epidemic are intertwined, and as a profession and society, we will need to continue to improve our diet and exercise habits to fix the root cause and ensure the health and well-being of our country. So these are the society guidelines in America on different things, just for your information if you're downloading the slides. And then these are my references. Thank you for your time.